Okay, so to finish up or continue with chapter 44, we left off with myasthenia gravis. So this begins on page. There, I just lost it. I was just on it and then I lost it. Page 917. Okay, so myasthenia gravis, an acquired autoimmune disease characterized, is what that should say, by muscle weakness. It may take many forms, from mild disturbances of the cranial and peripheral motor neurons to a rapidly developing generalized weakness that may lead to death from respiratory failure. It can present at any age, and incidence is slightly higher in men. The nerve pulses are reduced at the neuromuscular junction, so nerve impulses do not result in muscle contraction. I want to say, okay, so this is what your book says for us to break it down a little bit. Myasthenia gravis is caused by distorted acetylcholine receptors in the muscle motor end plate neurons. So the acetylcholine receptors that normally are going to take on acetylcholine have some kind of distortion going on. So what happens is that the antibodies will attach to these acetylcholine receptors. Because these antibodies attach there, a result is the nerve impulses are reduced at this neuromuscular junction that we were just talking about, and then therefore the muscle contraction does not happen. So that's what's happening inside a person that has myasthenia gravis. So you have 5 main classes of MG, all right? I listed them out for you. They're also listed out more in detail on page 917 and on 918. I included all the stuff that's in there, but you need to know this stuff, okay? So like with class 1, this is going to be something that is affecting only something with the eyes, okay? So class 1 is any ocular muscle weakness, may have weakness of eye closure, but all other muscle strength is normal. Any classification outside of class 1 is going to either be other muscles or both ocular muscles and other muscles. So like with class 2, you'll be able to read this. So class 2, mild weakness affecting other muscles and other than the ocular muscles. So page 917 does class 2A and class 2B. And just to give you this part, and then this is the last one I'll give you, you can read these. Class 2A says predominantly affecting limbs, axle muscles, or both. May also have lesser involvement in the oropharyngeal muscles. And then class 2B, predominantly affecting the oropharyngeal respiratory muscles, or both. So it's going to break all these up, and then 3 is moderate weakness, and there could be ocular. 4 is severe weakness, and there could be ocular. And then class 5 is the need for intubation. So there's a bunch of different management items that are talked about within your book. All right, so I just wanted to kind of go over this kind of quickly. You are going to want to make sure you read through, kind of like I talked about with the other ones. You make sure you read through, look at your vocabulary words and things that you might see. But so management, the first thing, plasmapheresis is used with MG, as well as we just learned about Guillain-Barré, GBS. So you could see plasmapheresis with that. Respiratory support, once again, because this can get to the point where a patient needs to be intubated. If it's more milder forms, promoting self-care guidelines, which are listed out in your book, things that we want to help the patient be able to do on their own, assisting with communication if they need it because of the muscle impairment. Again, nutritional support. So a lot of the stuff that we just talked about with GBS, it can be used with MG as well. Eye protection, so with both we had that as well with eye protection. It did talk about, was it this one that I talked about with the eyes? Nope, we're going to get to that other one in a minute. But eyes are also going to be an issue. Chewing for patients can actually end up being affected. That would be known as bulbar involvement. And then monitoring thyroid functions. So when you're reading, you'll notice, or hopefully you've read already, thyroxine, high, okay, so high thyroid hormone is present in a small number of MG patients, so we're going to need to make sure, we're going to need to be checking for that. Remember what some of your symptoms of hyperthyroidism would be, and so those are some things that we might possibly see in this patient because they would have basically hyperthyroidism during this outbreak of MG. So we want to make sure that we're watching for that. So health teaching, it's kind of just listed right there for you. You can read through this stuff in the book as well. I don't need to go through that. So peripheral nerves on page 923. This same exact man is standing on that page, but you can see it better than what you can see it here in my PowerPoint. So peripheral nerve trauma, okay? So common causative agents are listed out in your book. Vehicle or sports injuries, wounds to peripheral nerves such as knife or gunshot wounds, patients that have been injecting drugs, different, people that have been in the military and have had some kind of conflict in the military conflict where they ended up hurt. So it's you want to read through the degeneration, retraction of nerve distal to injury within 24 hours. That's in your book. And you also want to read the cold phase versus the warm phase on page 924. It actually talks about what you'll see in the first few weeks with the warm phase followed by the cold phase that happens. And it's important for us to know because then we know with peripheral nerve trauma what stage a patient is in. So you're going to see questions on the cold phase and the warm phase. So please make sure you read it. It's on page 924. Again, here you go. Page 924 has this same picture on it, goes into better detail, and you can, it's the same picture, but then there's the detail on it. You can go through that, and it'll be helpful for when you're studying for this next MedSurg 1 test. So, restless leg syndrome. We're going to deal with this with patients. Probably some of you have to deal with this. I deal with this all the time in Brighton. We have tons of patients that have restless leg syndrome. So this is leg paresthesias. It's an irresistible urge to move. There can be peripheral and central nerve damage in the legs and the spinal cord. So in your book, I actually highlighted some stuff that I wanted to read right to you guys if we were in class. So restless leg syndrome is characterized by leg paresthesias, which is burning, prickling sensation associated with an irresistible urge to move. Over 10% of the population in the U.S. have this problem, and women are affected twice as often as men. RLS occurs most often in middle-aged and older adults. Stress can exacerbate. RLS is related to a dysfunction in the brain circuits that use the neurotransmitter dopamine. Many of those affected with primary RLS have a positive family history, which suggests a possible genetic basis. The incidence is higher in patients who have diabetes, type 2, chronic kidney disease or iron deficiency, Parkinson's disease, peripheral neuropathy, use of certain medications such as caffeine, calcium channel blockers, lithium, and neuroleptics, and withdrawal from sedatives. There's that one right there that I have to deal with all the time. Although it's not a cause for hospitalization, it definitely causes significant issues for the patient. So, for our management, symptomatic RLS, we want to treat whatever the underlying cause is first, if we can, okay? That's always going to be your first intervention, is that I'm going to try to fix the underlying cause, if it can be fixed. So non-medical treatment that I can teach the patient, I can teach them to avoid alcohol, caffeine, that should say lose weight, stop smoking and exercise, non-pharmacological interventions for sleep, like a warm bath, stretching, warm milk. So we talked about all of that in class the other day. Same types of things here because RLS typically happens at nighttime. This is when people lay down to go to sleep and their legs just won't move. Now, people do have it during the daytime as well, but usually it's seen much more often at night, and then it causes insomnia for the patient. So different drug therapies that can be used, your book talks about ropinirole, gabapentin, benzos or opiates can be used as a last resort for the patient, but I think I mentioned in another screencast that in Brighton we actually use amantadine quite often for RLS, but we also use ropinirole and 600 milligrams of gabapentin at night for either insomnia or to help with restless legs. Facial paralysis, also known as Bell's palsy. This will be important to listen to because for a lot of people will associate Bell's palsy with some form of stroke because they have the drooping mouth and such. So we associate that sometimes with a stroke. So it's good for us to understand that Bell's palsy has nothing to do with a stroke. Okay, so this affects the 7th cranial nerve. So if you remember back to health assessment, that's going to be the facial nerve. It can also affect the trigeminal nerve and the vestibulocochlear nerve as well, according to your book, but it's mostly the facial nerve. So the cause is believed to be the result of inflammation triggered by formerly dormant herpes simplex virus type 1. So what that means is that the person had some form of herpes simplex virus, which I'm just doing great on typing today, in their body, but it's been dormant. It's just been sitting there. It's not been showing up in any form as like a cold sore or any other way. It's just been sitting dormant in the person's body, and something triggered it, and then it affected the person's 7th cranial nerve, causing the Bell's palsy or the facial paralysis. So it can be triggered by an infection, immunosuppression, or exposure to cold can happen that, and it's thought to reactivate the virus. And most patients will go into remission within 3 months. So in your book, it actually talks about how the maximum paralysis occurs over 2 to 5 days in most patients. There can be pain behind the ear on the face, and it may occur for a few hours or even days before the paralysis. The disorder involves a drawing sensation and paralysis of all muscles on the affected side. The patient cannot close his or her eye, wrinkle the forehead, smile, whistle, or grimace. Tearing may stop or become excessive. The face appears mask-like and sags. Taste is usually impaired to some degree, but this symptom seldom persists beyond the 2nd week of paralysis. Tinnitus, which is ringing of the ears, may also occur. Most patients go into remission within 3 months. So again, it's going to look like this drooping of the one side of the face, but it's not a stroke, okay? So hopefully you guys understand what Bell's palsy is now. Medical management that we can do, prednisone, steroids are used for this patient to work on the inflammation. We can also give a cyclovir, which is for the herpes simplex virus, and we can give analgesics for any kind of pain that they are experiencing. We need to teach them to protect the eye, so we've had other things we've discussed about protecting the eye, so we're going to be teaching about the eye drops and even the taping of the eye or wearing an eye patch. Nutrition can be affected. This is another condition in which we teach to eat high-calorie snacks because eating bigger meals may be more difficult. And then we teach about massage, warm, moist, and heat, facial exercises that the patient needs to do in order to help with the restorative process. And it's a very short section to read. It's from 927 to 928. They do a great job in your book outlining it and going through it. So if you have any further questions on that or want to go into it a little bit more, please read those 2 pages. They did a nice job with that. Okay, so we have one last chapter that we're going to get to after this, and I will be recording that shortly.